Hello everyone, this is Dr. Agalya Kulandevilu, your Gynec faculty. This session is a meticulous revision session on your gynecology where I am going to cover all your challenging concepts in gynecology including your image-based concepts as well as clinical concepts. So I hope this session will be very helpful for your exam. Let's start the session. First, we'll start with menstrual cycle. Okay, so menstrual cycle is a cycle which is going to have a series of events throughout the month and it will be happening in the uterus as well as in the ovaries, as well as there will also be hormonal fluctuations throughout the cycle, right? Now, if we divide the 28 days of a month into two halves, okay, 0 to 28 days, day 14 we will have ovulation, right? Here we will have the uterine cycle where we will have a proliferative phase in first half of the cycle and secretory phase in the second half of the cycle, as well as when we speak about the ovary, okay, ovarian cycle, there will be follicular phase in the first half of the cycle as well as luteal phase in the second half of the cycle. So here ovulation will be taking place and the first 3 to 4 days you will have menstruation here, right? Now, the hormone which is acting in the first half of the cycle is mostly going to be your estrogen, and in the second half of the cycle we have the progesterone acting. The estrogen can also act in the second half of the cycle, but remember progesterone is the main hormone that is acting in the second half of the cycle, right? So this is very important. Now, let's talk about the number of follicles. Okay, so you have to know the maximum number of follicles in a female is seen during her 20th week of intrauterine life, where it is going to be 6 to 7 million. Okay, and the second point is that at birth this will be reducing to only 1 to 2 million, and among this 1 to 2 million, only 4 lakh will be present at puberty, and from that 4 lakh, only 400 follicles will go for ovulation. Clear? Right. Now, let's also know this concept. Okay, actually, the germ cells are the one which will get differentiated into the oogonia. Okay. Now, this oogonia is going to enter into the first meiotic division. Okay. And you will get primary oocytes. And in this primary oocytes, there is arrest of development. Arrest of development. So, let's see in which phase it gets arrested. Okay. So, when you speak about meiosis, there are 4 phases in meiosis. Okay, that will include your prophase, metaphase, anaphase, and telophase. Okay, again this prophase is going to have 5 phases that will include your leptotene, zygotene, pachytene, diplotene, and your diakinesis. Okay, so this primary oocyte is going to get arrested in the diplotene phase of prophase of meiosis 1, and this arrest will be there till puberty. Okay, this concept is important, right? Now, during puberty what happens? We'll have so many primordial follicles. We'll have so many primordial follicles first, and among these primordial follicles, several of the follicles will be selected and they will be going into the primary follicular development, and among the primary follicles, a few will be selected and they will become the secondary follicle. Okay. So from the secondary follicle, only 1 or 2 will be selected and they will become a tertiary follicle. It is also known as what? Yes, it is also known as Graafian follicle. So when this stage is reached, almost the meiosis 1 will be completed. Meiosis 1 will be completed and you will have what? You will have your secondary oocyte and your first polar body, right? Now, again, this stage will enter into second meiotic division, where this will be arrested at the phase of metaphase. Okay, so the first halt is at the prophase till puberty. Then after the secondary tertiary follicle is formed, it will be halting at the metaphase stage. Okay, so this second meiotic division will get completed only after fertilization. After fertilization only second meiotic division will get complete. Okay, then there will be release of a second polar body. Clear? So this is how ovulation is going to happen, and the hormonal changes that is occurring with this, you have to know, is there will be LH surge occurring before ovulation, that will be happening about 34 to 36 hours before ovulation, and there will be LH hormone peak as well, that will be occurring just 10 to 12 hours before ovulation. Okay, so in the first half of the cycle, the hormone which is going to act mostly is your follicle stimulating hormone, and in the second half of the cycle it is going to be a luteinizing hormone. That's why it is follicular cycle and luteal cycle. More than that, it is also corpus luteum that is going to stay for almost 2 weeks after ovulation. Clear? And if pregnancy occurs, it will stay till 8 weeks till the placenta takes up the function of the corpus luteum. Clear? Right. Now, I want to discuss about this part, that is the Graafian follicle. Okay. So the structure of Graafian follicle is important for you. So the Graafian follicle measures approximately 20 millimeter in size before ovulation, and the layers of Graafian follicle is very important. Okay. If you move from outside to inward, the layers will include theca externa, then your theca interna. You will have granulosa cells then, that is membrana granulosa. You also have a granulosa cell layer itself. Then you will have the discus proligerus and the corona radiata with the ovum inside. Okay, you are able to see now, this is the cumulus cells, that is the corona radiata with the ovum inside, and also you will have an antrum that is filled with fluid. Okay, this is the antrum that is filled with fluid. Okay, so the layers that is surrounding the oocyte at the tertiary follicle stage is very important, right? Yes. Now, let's discuss about the changes that is taking place in the uterine endometrium now. Okay. So we have proliferative phase as well as secretory phase, right? So let's see the endometrial changes during these phases, right? So here you are able to see the proliferative phase, where you are able to see simple tubular glands, and the cells are with pseudostratification. Okay, pseudostratification. Pseudostratification means the nucleus is present at various levels, right? Also, in this stage, there will be increased mitotic activity. The stroma will be dense, and there is infiltration of cells as well. Clear? So you have simple tubular glands with pseudostratification. There is so much infiltration with the cells, increased mitotic activity, and the stroma is also very dense here, right? Next, coming to the secretory phase, you will see these glands have a corkscrew appearance, right? They have a corkscrew appearance. And you will see some pink deposits here. These are nothing but the secretions that are seen. Okay, secretions are seen inside the gland under the effect of the hormone progesterone, right? Okay. Now, using this endometrial biopsy, we can diagnose a condition called luteal phase defect. Okay, we use this kind of biopsy to find out luteal phase defect, which will be a cause of infertility. Okay, so what is happening here means we will do serial endometrial biopsies from early luteal phase itself, and if there is a lag of more than or equal to 2 days on histology related to the actual day of the cycle, then we will be calling it as luteal phase defect. This will be a retrospective diagnosis. Okay, more than 2 days or lagging between the histopathology report and the actual days of the cycle. That is luteal phase defect, right? Now, let's discuss about the cervical mucus changes that will be happening during the whole menstrual cycle. Okay, so something how I have to know is, what is this condition is called? Yes, this elasticity of the cervical mucus which we see during ovulation is called as spin Bargate, right? So it is spin Bargate. Okay, this can be applied as a test as well, which will be called as spin Bargate test as well as thread test. Okay, so there is excessive stretchability of the cervical mucus during ovulation, where it will become a thread-like and it can extend up to 7.5 to 10 centimeter. Okay, it will be seen just before ovulation under the effect of the hormone estrogen, right? Okay. Now, we also have something called as Fern test. Okay, so we have something called as Fern test. Here, the cervical mucus will be taken on a glass slide and it will be slide over, and when you see it under the microscopy, you will be able to see a palm leaf-like pattern. Can you see? So, here you have a palm leaf-like pattern. Palm leaf-like pattern. This is due to the crystallization of sodium chloride. And this is also happening under the effect of estrogen in the pre-ovulatory phase. Okay, so this will be seen starting from your day 5 to day 6 of the cycle, but it will be maximum 24 to 48 hours before ovulation, and it will disappear after ovulation. Once ovulation is done, this change will not be seen. So that means what? It is effective only under the action of estrogen hormone. Now, if there is a clinical question which tells you that the patient cervical mucus test was done and it was taken on day 21 to 22 and still there is ferning seen on the slide. That means what? Yes, that means the patient has an ovulation. She has not ovulated. Okay, because by 14th day ovulation would have happened. The effect of estrogen would have become less, and under the effect of progesterone this ferning will not be seen. And under the effect of progesterone, what you will see means you will see something like a beaded cellular pattern. Okay, so still ferning is present means, that means the woman has an ovulation. Clear? Right. Now, coming to the next discussion, that is semen analysis. Okay, so semen analysis is very important for you. All the parameters itself is a question. Okay, so you have to know all these parameters thoroughly. Ejaculate volume is 1.5 ml, pH will be 7.2, the sperm concentration is 15 into 10 to the power 6 spermatozoa per milliliter, total sperm number is 39 into 10 to the power 6 per spermatozoa per ejaculate. Okay, sperm concentration means per ml we are seeing that is 15. Sperm total sperm number means per ejaculate we are seeing that is 39, right? Then total percentage motility should be 40%, in that the sperm which is showing forward motility should be at least 32%, and normal morphology should be at least 4% of the sperms should have normal morphology, and sperm agglutination should be absent, and the viscosity will be less than 2 or equal to 2 thread after liquefaction. Clear? So this is all about your semen analysis test. Now let's discuss something on physiology of semen after ejaculation. See, I told something called as liquefaction. The semen during ejaculation will be a gel-like consistency, and it will take approximately 20 minutes for the semen to turn into a liquid one. Okay, there will be series of changes that will be taking place in the sperm after ejaculation. The first change it will undergo is capacitation. So capacitation means it is an activation process. It is an activation process that involves both enhancement of flagella activity, that is the sperm movement will become more active, as well as there will be biochemical and structural changes that will be seen in the sperm head. Clear? Now let's see the structure of the sperm. We have the head, midpiece and the tail. In the head, we have the acrosome and the nucleus, and the midpiece consists of mitochondria, and the tail consists of eggshell filament, right? So this acrosome is important because it brings about something called as acrosomal reaction. So this acrosome consists of hydrolytic enzymes in it. So when a sperm is meeting a egg, what happens? There will be a reaction that will be releasing the hydrolytic enzymes from the acrosome that will be digesting all the contents that will be surrounding the egg. We have seen the structure of graphene follicle, so you know how much layers the oocyte is being surrounded. So all these layers will be digested by this acrosomal enzymes. Then there will be something called as cortical reaction. Now, the cortical granules that are present in the egg will be releasing enzymes. And finally, we'll also have something called as zona reaction. So this is nothing but modification of the zona pellucida in response to fertilization. So that will have a block to polyspermy. Okay, so the order in which these reactions are taking place is important. It is acrosomal reaction followed by cortical reaction followed by zona reaction. Okay, so it's just in the alphabetical order. It is A, C and Z, right? Yes. Now, so this is the pic to show your acrosome reaction, where the acrosome is going to release some enzymes. Then you will have the cortical granules that will be releasing enzymes. Zona reaction means a change in the zona pellucida that will make it thicker, even more thicker, to prevent polyspermy. That's it, right? Yes. Now, let's also see some of the changes that will be seen when there is any abnormality in the sperm characters, right? So these terminologies are also important. So we can have aspermia when there is no ejaculate at all. Then it will be called as azoospermia. That means no sperm in the ejaculate. Oligospermia means the sperm density is less than 20 million per milliliter. Severe oligospermia means the sperm concentration is less than 5 million per milliliter. We can have teratogenesis zoospermia, where you have so many abnormal sperms. Okay, that is the morphology is not normal. Something called as asthenospermia. Astheno means about the speed. Okay, so there is decreased motility or there are more immotile sperms. This is what you have to remember. Okay, and there is also another term, that is necrospermia or necrozoospermia. That means there is increased number of non-viable sperms. Okay, now they will give you a question like this. What is oligoasthenoteratozoospermia? The patient has oligoasthenoteratozoospermia. So that means the patient has low sperm concentration, he has dead sperms, as well as the sperms are also having very less motility. Clear? Now let's talk about a syndrome called as Klinefelter syndrome, where the patient will have azoospermia. So mostly these patients are males with few births. They will have gynecomastia, soft and small testes, and also azoospermia. The karyotype of these people is 47XXY. Okay, and Klinefelter syndrome alone constitutes about 14% cases of azoospermia. Right? So this is important. So this is a Klinefelter where you are able to see a male who is taller, less muscular body. So this male is taller, who has less muscular body compared to the males of his age. He has broad hips and longer legs. He has large breasts, that is gynecomastia. He has weaker bones. He will have low energy level, smaller penis and testicles. There will be delay in the puberty and less facial and body hair following puberty. Okay, he is a Klinefelter. The karyotype is what? It is 47XXY. Right. Now, let's discuss about the histopathology of testis. Okay, so histopathology of testis, normally when you see, you have a central lumen and surrounding you will be able to see so much of germ cells. Okay, that is, you will be able to see a spermatid, a spermatogonium. Okay, you have a primary spermatocyte, like that you will be able to see, and also you will be able to see Sertoli cells. Okay, Sertoli cells, these are the less stained cells which doesn't have any spermatid at all. A spermatid is one something you will see like this. Okay, but a Sertoli cell is only a supporting cell which doesn't involve in spermatogenesis. Okay, so there is a condition called Sertoli-Wandley syndrome. Sertoli-Wandley syndrome, where you don't have any germ cells and you have only Sertoli cells. Okay, so these people are usually young. Okay, they present at younger age itself, between 20 to 40 years, and they will have primary infertility. So this diagnosis can be made on the testicular biopsy, where you will be able to see only Sertoli cells, and there will be also thickening of the tubular basement membrane. Okay, you are able to see the thickening of the tubular basement membrane as well. Okay, so this is Sertoli-Wandley cell syndrome. Right. Now, in this picture, they are showing a female whose short stature with broad chest, there is curvature of spine, widely spaced nipples, there is elbow deformity, and this seems to be like a cubitus valgus, right? Then there is a short fourth metacarpal, pubertal failure, brown spots, knee deformity, structural abnormalities of the kidney. She has congenital heart disease. Any history of congenital heart disease, same like a mitral valve prolapse or a bicuspid aortic valve, like that. There is broad, short appearing webbed neck, and there is low set ears, low hairline, and ruby eyelids. What do you think? Yes, it is going to be Turner syndrome. So a Turner syndrome question is also very important. They can ask it in any way. They may just give you the clinical features, or they may ask it as a case of primary infertility. That is the most common presentation of Turner syndrome, right? So you have to know that Turner syndrome is the most common syndrome of gonadal dysgenesis. This constitutes about 50 to 60% of the cases of gonadal dysgenesis. And then the karyotype of these patients. Karyotype is going to be 45x0. There can also be mosaic Turners where they will have 45x0 by XX. Okay, so in these patients, since some cells are mosaic and some cells are having 45x0 karyotyping, the features of the typical Turner syndrome will not be present, right? Yes. We have to discuss another syndrome of gonadal dysgenesis, that is Swyer syndrome. Let's see the difference between Turner syndrome and Swyer syndrome so that you will learn both as well as you know how to differentiate between them. A Turner is going to carry a karyotype of 45x0, whereas in a Swyer it will show 46xy. We know Turner's is most common than Swyer syndrome, but Swyer syndrome is a pure gonadal dysgenesis. Okay. Turners are short people, whereas in Swyer they will have a normal stature. In Turners, prepubertal external genitalia is seen, whereas in Swyers they will have normal pubic hair and normal internal genitalia. Breast is absent in both or poorly developed. Poor or absent. Okay. In Turner's, dysgenetic gonads are present, and in Swyers there is gonadal dysgenesis, but even when some amount of gonadal tissue is present, you have to offer them gonadectomy because of the chromosome Y present in Swyer syndrome, because they have a high risk of developing germ cell tumors. Right? So when you see a similar picture, you have to look on this clinch. Okay? So when it is a short person, he is going to be Turner's. When he is a tall person or a normal height, he is going to be a Swyer syndrome. Right? Now when they are phenotypically female and the karyotype is showing you XY, you have to consider two syndromes, complete androgen insensitivity syndrome and Swyer syndrome, right? So in complete androgen insensitivity syndrome, breast is well developed, okay, whereas in Swyer syndrome is poorly developed or it is even absent sometimes, right? And the next one is about the pubic and axillary hair. They are absent in complete androgen insensitivity syndrome, whereas it is present in Swyer syndrome. Vagina is going to be blind in complete androgen insensitivity syndrome, whereas the vagina is normal in Swyer syndrome. Uterus is going to be absent in complete androgen insensitivity syndrome, whereas it is going to be present in the other syndrome. Next one is the gonads that is present in complete androgen insensitivity syndrome is going to be your testis. Yes, is going to be your testis, and the gonads in Swyer syndrome is going to be streak gonads. Okay, streak gonads. So here the testosterone levels are of normal male levels, whereas here the testosterone hormone is of the normal female levels, right? And here you have to understand one thing, since the uterus itself is absent in complete androgen insensitivity syndrome, the menstruation and reproduction are not possible. reproduction are not possible. Whereas in Swyer syndrome, menstruation can be brought about by hormonal supplements and reproduction can also be tried by donor mechanisms or any artificial reproductive techniques, right? So this is all about complete androgen insensitivity syndrome and Swyer syndrome. Now you will ask me, ma'am, what is this complete androgen insensitivity syndrome? See, complete androgen insensitivity syndrome is a syndrome where there is going to be defect in the androgen receptor. Okay, so the androgen hormone will be produced somewhere and it has to go and act on a particular receptor to produce its effects. Okay, so that receptor itself is absent. Okay, or otherwise, a hormone called dihydrotestosterone, which is being produced from the hormone testosterone by 5-alpha reductase. This hormone is responsible for the complete external male genitalia differentiation. Suppose if this hormone is going to be absent, then also the features, the phenotype is going to differ, right? So, complete androgen insensitivity syndrome, partial androgen insensitivity syndrome and 5-alpha reductase deficiency are the three types of androgen insensitivity syndromes we have. There has been questions on complete androgen insensitivity syndrome as well as your 5-alpha reductase deficiency in your previous papers, right? Okay. So let's see the inheritance of complete androgen insensitivity syndrome. The inheritance is going to be X-linked recessive in both your complete and partial androgen insensitivity syndrome, whereas in 5-alpha reductase deficiency, remember it is an enzyme defect. All enzyme defects will be going to fit into the autosomal recessive type, right? So it is going to be a autosomal recessive disorder. Then the defect, as I told, the defect is going to be in the androgen receptors, okay, in both complete androgen insensitivity syndrome as well as in partial androgen insensitivity syndrome. There can be any mutations or the receptor can be inactive, okay. So the same thing applies here also. And in 5-alpha reductase deficiency, I already told you the enzyme is deficient. So testosterone to dihydrotestosterone conversion is not going to happen, right? Next is external genitalia. External genitalia is going to look like a female in complete androgen insensitivity syndrome, whereas in partial androgen insensitivity syndrome and 5-alpha reductase deficiency, this is going to be ambiguous genitalia. Internal genitalia in all the three types is going to be look like a male. So what is going to be the gonad? The gonad is going to be testis, right? And the presentation of complete androgen insensitivity syndrome, see, their external genitalia looks like a female. Only the internal genitalia and gonads are going to be male. So at birth itself, we are not going to test for the gonads, right? So by looking at the external genitalia only, we assign the sex. So these people are mostly reared like females till puberty. And at puberty, when there is amenorrhea, then only these people will be coming to us. Okay, so the presentation will be mostly at puberty, okay. Whereas in partial androgen insensitivity syndrome and 5-alpha reductase deficiency, they can be presenting at infancy itself because of the ambiguous genitalia, right? So they can present at infancy. So the phenotype in complete androgen insensitivity syndrome is completely like a female. Okay, they will look completely like a female with well-developed breast also, right? In partial androgen insensitivity syndrome, they are going to be partly masculine and they will have gynecomastia. Okay, they will have what? Gynecomastia. In 5-alpha reductase deficiency, the phenotype is going to look more like a male. Okay, so they have a masculine phenotype. Okay, so this differentiation you should know well. Clear? Right. Now, let's go on and discuss about androgen insensitivity syndrome and Mayer-Rokitansky-Kuster-Hauser syndrome. Okay, because there will be similar features as well as differentiating features also. This can also be a point of confusion while you give your exams, right? Yes. So, the breast in androgen insensitivity syndrome, that is complete androgen insensitivity syndrome, which is also known as TFS, that is testicular feminization syndrome, and MRKH. Okay, so the breast is well developed in both. Pubic hair is going to be absent in complete androgen insensitivity syndrome. Yes, we know that. And in MRKH, this is going to be normal. Vagina is going to be blind in both the syndromes. Uterus is going to be absent in both the syndromes. The gonad is going to be testis in androgen insensitivity syndrome, and it can vary in location, whereas in MRKH syndrome, this is going to be normal ovary and it is going to be present at the normal site. Testosterone levels are in the normal male range, and in MRKH, the testosterone levels are going to be in the normal female range. Karyotype in androgen insensitivity syndrome is going to be 46XY. Okay, whereas in MRKH syndrome, it is going to be 46XX. And we know inheritance of androgen insensitivity syndrome is going to be X-linked recessive, whereas there is no such inheritance seen in MRKH syndrome. Clear? So, what does Mayer-Rokitansky-Kuster-Hauser syndrome means? It is a syndrome of complete Mullerian agenesis. Okay? Complete Mullerian agenesis, where the uterus, then the fallopian tubes and upper 2/3 of the vagina is going to be absent. Since only 1/3 of the vagina, that is lower 1/3 of vagina is going to be present, it will be appearing like a blind vagina or a vaginal pouch. Okay, they will have the ovaries. Ovaries will be present in them. Okay, when you do an investigation in them, you will be able to see such a feature. Okay, where the uterus and the upper 2/3 of the vagina is going to be absent. Okay, so this is not seen here in MRKH syndrome. Now, let me tell you something about embryology. Okay, it will be helpful for the following sessions as well as to understand your MRKH syndrome as well, right? So, what happens? I am not going to teach it in detail, don't worry. Just a few clinching points to make you understand the concept. That's it, right? So, we have two Mullerian ducts. Okay, so Mullerian ducts are the structures which are going to give rise to the female internal genitalia. Okay, Mullerian ducts are also known as paramesonephric ducts, and these two ducts are present on both the sides, that is one on the right side, one on the left side, and what they will do is at a point they will start fusing from the caudal to the cranial direction. Okay, so in this direction they will be starting their fusion. Okay, right. So caudal to cranial direction, right? Now what happens when they are fusing? Yes, entire thing is going to fuse and the central septum will be there. Okay, because of the fusion there will be a central septum. It will be going for resorption. Okay, the midline septum so formed by the fusion of the two ducts will go for a resorption. That's how an endometrial cavity is formed, and these cranial end of the Mullerian ducts are going to be open. That's how we have the fimbria that is going to open into the peritoneal cavity. Okay, and if you speak about the vagina, we have the cloaca, which is going to divide itself into urogenital sinus and primitive rectum, right? Now, from the urogenital sinus only, we will get the lower 1/3 of vagina. Okay, whereas Mullerian ducts will be forming the upper 2/3 of vagina, right? So, in Mullerian agenesis, what is going to happen? Mullerian ducts are completely absent. That's why you don't have upper 2/3 of vagina as well as the fallopian tubes, but you will have the lower 1/3 of the vagina. And we know the gonads, that is the ovaries, are derived from the gonadal ridge, right? So, they are going to be present. Okay, and yeah, that's all you have to know. Okay, so that's why you have a vaginal dimple, and this how it happens. But there can be so many abnormalities that can be arising during the formation of uterus or the internal female genitalia, right? So this much abnormalities you can have. Okay, so a normal uterus will be formed like this, whereas this is a uterine hypoplasia or uterine agenesis, that is Mullerian agenesis we have discussed now. Then you can have unicornuate uterus, that is only one side of the uterine horn will be present. Uterine diadelphus, the both horns are going to be present, but there is no unification. Then bicornuate uterus means lower part is fused and the cornua part is not fused. Septate uterus, the septum is not going for a resorption. Then arcuate uterus, the shape is somewhat deformed, but it is going to be otherwise normal. Then you have a diethyl stilbestol drug related uterus, which will be having a T-shaped uterine cavity. Clear? Right. Now, when we do an HSG, okay, that is hysterosalpingogram image, you will find like this. Okay, so you will have, when you give a dye to the cannula, that cannula name is Leach-Wilkinson cannula, you will be able to find the normal shape of the uterus like this, and you will be able to see a spill that is coming from the right tube as well as the left tube, because I told you already the tubes are going to open into the peritoneal cavity, right? So the spill should be seen to make sure that the tubes are not blocked, right? Suppose if the spill, if you don't see this kind of spill in any HSG image, then you have to think about the tubal block. Clear? Right. Now, let's see all the abnormalities in HSG images. Okay. So, this is a image where you are able to see only one horn of the uterus being present. So, what is this going to be? It is going to be a, very good, it is going to be a unicarnovate uterus. Okay. So, here if you see a deviated, a banana shaped cavity, right? And this is going to have a single fallopian tube also, since you are not able to make the fallopian tube itself here, but you have to make sure that the dye is going in only one side, means then it is going to be an unicarnovate uterus. Okay, a single deviated banana shaped cavity. Clear? Right. Now, coming to this picture, this is uterus diadelphus. Okay. So, what is going to happen in uterus diadelphus? There is failure of fusion of the Mullerian ducts. The two ducts are going to grow as it is. There is no unification at all. Okay. So, that is uterine diadelphus. So, what you will have? You will have two uterus, and the two uterus will have two endometrial cavities also. Then you will have two cervixes as well. Okay, so that is how uterus diadelphus will be. Okay, so because it has two cervixes, in most of the HSG pic, if you get a uterus diadelphus, they will show you two Leach-Wilkinson cannula like this. Okay, so this is an instrument. So this is a cannula. So if you are able to see two Leach-Wilkinson cannula while giving a HSG picture, then you have to make sure it is a picture of uterine diadelphus. Okay, so this picture has two symmetrical cavities that are separate, as well as two cervical canals as well. Okay, so this is all about uterus diadelphus. Now, if you ask me, is pregnancy is possible in uterus diadelphus? Yes, pregnancy is possible, but there is a risk with pregnancy in uterus diadelphus. So let's see what are the risks. Okay, that will include spontaneous abortion, preterm labor, there can be low birth weight or breech presentation, and need of a cesarean delivery. Okay, so these are some of the risks that are associated with pregnancy in uterine diadelphus. Right, coming to this image. Okay, so here what do you see? Here you see a uterus. The fundus is somewhat abnormal, right? So the fundus is somewhat concave, right? So normally if we see in the previous picture, okay, you have a straight fundus like this, right? Whereas here you are able to see the fundus is somewhat concave like this. Okay, so the concavity is changed here, and both the fallopian tubes are going to be patterned because you are able to see the spill. So what do you think this one is? This one is going to be an arcuate uterus. Okay, so only the fundal shape is changed. Okay, so this is going to be an arcuate uterus, right? Yes. Coming to the next one, where we are able to see two pics. I place these two pics to show you two abnormalities, and there will be a lot of confusion as well. Okay. Now, if you see this pic, you have only one Leach-Wilkinson cannula here. So, only one cervix, and you have two uterine horns and two fallopian tube spills. So, you have two uterine horns. So, what do you think this one is? This one is going to be a, yes, this one is going to be a bicornuate uterus, right? But there is a close differentiation feature for this bicornuate uterus. Yes, that is going to be a septate uterus. Okay, so I will show you how it is going to be close differentiating feature. See, in a bicornuate uterus, you have two cornua, two endometrial cavities here, right? You have something in the center. In septate uterus also you have something in center, and you have two endometrial cavities as well, right? The only thing that is going to differentiate between a bicornuate uterus and a septate uterus is going to be the uterine fundus, where in the bicornuate uterus there is going to be dimpling like this, whereas in the septate uterus this is going to be look like a normal uterine fundus, right? So that's why a HSG is of no use in differentiating between a bicornuate uterus and a septate uterus, and whenever you want to differentiate between these two, you have to offer them an ultrasonogram or you have to offer them an MRI. Clear? Yes. Coming to this HSG picture. So what do you see here? See, we are giving the dye, but there is a defect, okay, only in some area inside the cavity. This is inside the cavity. There is a defect. It is not getting filled properly. So what do you think? Yes, it is going to be Asherman syndrome, right? Yes. So it is going to be Asherman syndrome. So where you have many irregular filling defects. Okay, irregular filling defects are there. Right. There is some spillage in the left tube seen. Okay, so these are due to, why this is happening? These are due to intrauterine adhesions. Okay, so intrauterine adhesions or intrauterine synechiae. So what are the causes for intrauterine adhesion formation? The causes will include, most important causes, dilatation and curettage that you will do for taking any endometrial biopsy or any missed miscarriage, incomplete miscarriage like that, and sampling, also polyps, okay, polyp removal when you do. Okay, so these are some of the causes. And when you ask me why these adhesions are formed, about the pathophysiology of Asherman syndrome, there is injury to the basal layer of endometrium. Injury to the basal layer of endometrium. So this will trigger inflammation and allow the adhesive bands to be formed from one side of the cavity to other side of the cavity, right? So how they will usually present to you? Okay, the presentation, clinical presentation of Asherman syndrome, they will usually present with amenorrhea, mostly a secondary amenorrhea, obviously, right? Then hypomenorrhea, or even dysmenorrhea. Okay, you can offer them a 2D ultrasonogram or a HSG or even a saline infusion sonography. Okay, however, the gold standard investigation for Asherman syndrome is going to be hysteroscopy, because when you give hysteroscopy, it is not going to only investigate the Asherman syndrome, we can also treat it simultaneously. That is, you can offer them hysteroscopic adhesolysis. Okay, so even by hysteroscopy you are not able to make it, then you can go for MRI. Clear? Right. Now Asherman syndrome can be divided into 3 types. You have an AFS classification. Okay, so where Asherman syndrome can be divided into 3 types. One is mild, moderate and severe. In mild type, you will have filmy adhesions, and in moderate type you will have filmy to dense adhesions, and definitely in severe type you will have dense adhesions. And in mild type, the adhesions will be seen in only 1/3 of the cavity, less than 1/3 of the cavity. Here 1/3 to 2/3 of the cavity, and here more than 2/3 of the cavity. Okay, and first 2 types will be presenting with hypomenorrhea. Okay, whereas the severe type can present with amenorrhea. Clear? So, management I already told you, you can go for hysteroscopic adhesive lasers. Another option is you can offer to keep adhesive gel that is containing hyaluronidase. Clear? Yes. Now, coming to the next one. So, this picture. So, what do you show here? What you are able to see here? See, this uterus is somewhat smaller in size. Yes. And it has, see, the borders are not regular as well. And then you have diverticulae. Okay, you have many tubal diverticulae here that is noted in both the fallopian tubes, and you have some beaded appearance as well. See, you are able to see the beaded appearance, and in this side, you're able to note a golf-like shape, right? So like this. Okay, so all these are pointing towards your genital tuberculosis. So what are the features we have observed? The uterus is small in size. It shows irregular borders. You have beaded appearance of both the tubes, and the distal portion of the tubes is showing a golf club appearance. Okay, and one more thing to notice, you don't see any peritoneal spillage also, right? So no peritoneal spillage. So this picture is mostly suggestive of genital tuberculosis. Is that clear? Right. Now, well, this is another one where we have to note there is spill that has come to the tubes, but you see it is much excessive. Don't you think there is excessive spill? So this is going to be hydrosalpinx. Okay. So what is hydrosalpinx? That is a distended fallopian tubes. So where do you get hydrosalpinx? So causes will include endometriosis, pelvic inflammatory disease. So mostly pelvic inflammatory disease will be the cause, or it can occur after tubal ligation or even after tubal malignancy, right? Yes. Now, in ultrasonogram, when you see, these tubes will be thin or thick-walled structures, that is elongated or folded, C or S-shaped, and the tubes will be seen distinct from the uterus. Okay, they will lie separately from the uterus. Okay, so distinct from the uterus as well as ovary. Okay, so this is one of the laparoscopic picture of your hydrosalpinx. Okay, hydrosalpinx will be a cause of infertility because the collection, that is the fluid that is present inside the tube, is going to be toxic to the fertilized embryo. Okay, embryo toxic, right. Now, this classification is very important. Okay, classification of causes of AUB. It's put into POM and COIN. Okay, POM will be talking about the structural causes of AUB and COIN will be talking about the non-structural causes of AUB. Okay, so what is P? It is going to be polyp. A is going to be adenomyosis. L is going to be leiomyoma. M is going to be malignancy and hyperplasia. Then C is going to be coagulopathy. O is going to be ovarian dysfunction. E is going to be the causes anything related with the endometrium, and I is going to be any iatrogenic causes, and N is, it is not otherwise classified. For example, a cesarean section scar defect. Clear? So this POM COIN classification is very important. Now here we have a hysteroscopy picture. Okay, so when you see something like this, it is going to be a hysteroscopy picture where you are just viewing the endometrial cavity. Okay, so inside endometrial cavity, what you are able to see? You are able to see something that is protruding from the endometrial cavity, right? So what do you think this is? This is going to be an, yes, very good. It is going to be an endometrial polyp. So usually the endometrial polyps are soft fleshy growths. These consist of endometrial glands, fibrostroma, as well as surface epithelium. Okay. Symptoms of endometrial polyp can be heavy menstrual bleeding or an intermenstrual bleeding, and TVS can be done as an investigation of choice with color Doppler. Okay. So what you will see is, you will be able to see a single feeding vessel when you put color Doppler. Okay, so this is how it will be. You are able to see an endometrial polyp here that is arising, and you have a single feeding vessel like this. Okay, so this is going to be an endometrial polyp. Suppose you are able to see multiple vessels like this, then it is going to be a leiomyoma or a fibroid, right? Yes. So this is another picture. This is a saline infusion sonography where you are able to see the endometrial polyp separately from that of the uterus. Okay, and the saline is sitting between the uterine wall and the polyp. Clear? Right. Now, okay, suppose if they give you any kind of abnormal uterine bleeding history and they give you the specimen. Okay, so here you see what? You see a uniformly enlarged uterus. Okay, in the full specimen. Whereas in the cut section, you are able to see small cyst. Right? So these are small cysts that is seen. So what do you think? Your diagnosis is now going to be? Yes, it is going to be adenomyosis. Adenomyosis. Now let's discuss something on adenomyosis. So adenomyosis is a condition where the endometrial glands and the stroma are going to present in the myometrium. Okay, and also you have myometrial hyperplasia as well. Clear? So what are the three layers of the uterus? You have the endometrium, you have the myometrium, and you have the parametrium. So the endometrial glands and stroma are going to be present in the next layer of uterus, that is in the myometrium. So that is what we call as adenomyosis. Clear? Right. So gross, as I have told, it is going to be a uniformly enlarged uterus, and remember, it is not going to be more than or equal to 12 weeks. Okay, and it has a smooth surface and it looks soft also. Okay, so this is how your gross picture will be, and it is going to be, yes, uniformly enlarged, right? And on cut section, you will be able to see some hemorrhagic areas sometimes. Then it will look somewhat spongy with trabecular appearance. Okay, right. Now, one more thing you have to notice, because there is the endometrial glands and stroma are coming to the myometrium and there is myometrial hyperplasia, the junction that is present between the endometrium and myometrium, that is called as junctional zone. Okay, junctional zone is going to be thickened, and there is also going to be weakened smooth muscle tissue. Weakened smooth muscle tissue. So normally this junctional zone will be around some 7 to 8 millimeter only, but in adenomyosis this will be more than or equal to 12 millimeter. Clear? So what will be the investigation you will offer them? Investigation you will offer them will be ultrasonogram, right? So ultrasonogram, your pelvic ultrasonogram is going to be the primary imaging modality you will offer when you see such patient. Okay. So what you will be able to observe is, you will be able to observe ectopic endometrial glands, and you will have irregular as well as thickened endomyometrial junction. So what is the thickness? It is going to be more than 12 millimeter. Then you will also see tiny anechoic myometrial as well as subendometrial cyst as well. Okay, so tiny means this can be between 1 to 5 millimeter, and the subendometrial cyst is going to be more specific for adenomyosis, right? And there is also increased vascularity. Clear? Yes. You will also be able to note something called as Venetian blind appearance. Okay. You will also appreciate something called as Venetian blind appearance. These are nothing but the linear striations like appearance because of the parallel shadowing you see. Okay, but the imaging modality of choice is going to be your MRI. You will be able to diagnose and characterize adenomyosis. Okay, so what will be the management? Management is mostly symptomatic management. Okay, if there is pain, you give analgesics. If there is bleeding, you try to stop the bleeding, like that. So it is symptomatic management. Then they will present with infertility. For infertility, you will go for ovulation induction. And suppose if the symptoms are more severe, then yes, definitely you will offer them hysterectomy, right? Yes.